Hello, everybody. Welcome to MS Views and News' first program in the state of Arizona. Arizona! Yay! Everybody here. Thank you. So my name is Stuart Schlossman. I'm president and founder of MS Views and News. That's a long story in itself. We're not going to get into that. Today's program is our Compass MS Care series. We have been doing this for about 6 years, getting out into underserved and rural America primarily, although we do get into cities as well. But the primary purpose is to provide for communities that are not hearing from the doctors about like a wide array of things about multiple sclerosis. So it's not really about one medication, it's about symptom management, access to care, disease progression, and so on. So these are the reasons why we bring these programs around the country. So to go forward, I just want to let you know that our sponsors for today's program is Banner Life Sciences, Bristol-Myers Squibb, and we have Genentech. All right, and then we have a lot of exhibitors. We had a slew of exhibitors here today, and I'm sure they're here for our doctors speaking, but we have Banner Life Sciences, Genentech, Horizon, Janssen, TG Therapeutics, Biogen, Novartis, ourselves, and the National MS Society, and we want to thank them for being here as well. So today's program, Dr. Barry Hendin is board-certified neurologist with over 45 years of experience and a special interest in clinical interest in multiple sclerosis. Originally from Missouri, Dr. Hendin received his medical degree from Washington University Medical School in 1968. He interned in St. Louis at the St. Louis Jewish Hospital from 1968 to 1969 and completed his residency and fellowship at Barnes Hospital in Missouri in 1972. He relocated to Arizona in the mid-70s. Dr. Hendin is board certified by the American Board of Psychiatry and Neurology. He has been named a top doc every year by one between 1995 and 2019 and is the only neurologist to have received this honor more than 20 times. Yay. Okay. He was also named Health Professional of the Year by the National Multiple Sclerosis Society Arizona chapter in 2007 and 2009. Dr. Hendin currently sits on the National MS Society Board of Directors in addition to serving as the Chief Medical Officer for the Multiple Sclerosis Association of America. I think MS Views needs to get him also. All right. With a passion for research and teachings, as well as treating patients, he educates future doctors as a clinical professor of neurology at the University of Arizona Medical School and is involved in teaching locally, nationally, and internationally on topics related to multiple sclerosis. I'm not going to keep going on and on and on. This guy, I can be here all day, and you'll have to listen to me all day, slurring my words and shaking the paper. So let's just welcome Dr. Barry Hendin. You're going to take the steps up? It's a big step. Great, thank you.
So hello to everybody. I told Stuart that my idea of today was a fireside chat minus the fireplace, and that what I really wanted was something highly interactive. I think it'll fall a little short of that because given the technology, it's more me talking for a while and then you all asking questions. But there are three topics. Topic number one is progression in MS. I'll spend a little while because it's a changing topic. Topic number two will be the disease-modifying therapies, the therapies for MS. Topic number three will be symptomatic therapies for MS. And then I'll stop and listen, and you'll all ask questions, and there may be some elsewhere too. But I'm delighted to see you all. So when I began to think about the first topic, which is progression in MS, I thought it has to be considered from multiple lenses. The lens of the neurologist, of course, a kind of a biological lens, and your lens, the lens of the patient, the lens of the person with MS. So what Stuart said I wanted to do unusually, and I would have probably liked to do it all during this discussion, is say, let's start with you all. If we're going to talk about progression, I know you're not used to being the on-camera person necessarily, but it's so essential that we think about not just what progression means from my lens, but what progression means from yours. If any of you are willing, please be willing, if any of you are willing, raise your hand and just give your thoughts. And all I mean is what MS progression means to you one way or another, just so we all get to hear that. And we all means we all locally, but we all nationally. So, Stuart, if you don't mind, is there anybody who's willing to say, here, when I think of MS progression, here's what I think of?
I think about yet another symptom and maybe a debilitating symptom that takes me in a different direction from my current life.
Thank you. Perfect.
Hi, I'm thinking the same thing. Even though I know I'm progressing and my neurologist says, well, no, I'm not, then why is it that I now need to wear a bag? Or, so I'm progressing.
So 2 comments, and I want to highlight both of them. One is, it is worsening things that you could do or could do more easily, that now get harder or more intrusive, with symptoms more intrusive over time. With you add the second part of that I think is so essential, and that is, why, if I know I'm progressing, does my clinician tend not to acknowledge it so much? And I'll get to that as a topic because I think it's actually worthwhile. Anybody else with great courage want to add a word or two? I'm looking at you. Did you decide you wanted to? Yes, you, of course I'm looking at you. Did you want to say a word? So, Stuart, I think there is
Well, I got somebody online that wants to say something too.
Sure.
All right, remember, we have another component here. All right, so my fear is getting worse and not having any family or friends around to help me.
The sense of worsening and consequent social isolation. Again, a theme. I want us to keep hearing these things. Sometimes I think, again, we're in a room of experts. Experts in the back. You'll see a lot of people who I know and love in the back who are experts in MS. You all who are experts in MS. Stuart, and I know a little. So next, what's progression? What's your thoughts about progression?
I guess my fear is getting to the point that I am unable to care for my children before like a reasonable time in my life. And I guess the effect that I have on my family and how they have to watch me
You use the term
go down.
You use the term really two things. One is fear, and the other is function, and that is, I fear that I will lose function, and those functions, including motherhood, are so important to me. Thank you, by the way. It's a good start, but anybody else have thoughts? That means
I do.
Stuart.
You ready?
Sure.
Not enough medications for primary progressive MS.
Not enough medications. So you're saying unmet need. Good.
Progression means to me never going back.
Progression means never going back. I'll address that too. At some point, I'll talk about progression and worsening. And I will say that they're not identical terms. They're often used as if they're identical terms, but I'll try to tell you something a little more hopeful about. Progression isn't when we say it the world's most hopeful term. I'll try to add a little bit of nuance and hope to that if I can. So we've gotten enough. I think enough comments that people with MS, i.e. the patient voice, that I really wanted us all to hear. And that means hearing yourself, hearing each other. Its progression can be viewed. The second lens is the science. What's the science of progression? And the third question is, what about the clinicians? Have we caught up? Are we talking about it in the same relevant way?
Two more from online, please.
Sure.
Okay, great. All right, one writes, progression is scary and inevitable. And the other person writes, I feel like I'm literally stumbling through life.
So two things. One is fear again, scared
and
again.
Another one just popped up, loss of independence.
Sure. I've got to tell you, Stuart, what I've got to say is actually far less essential than what you're hearing. Go ahead.
That's it.
That's it.
You're up.
And stumbling. And so gait is part of what you're hearing. Stumbling means gait. And I'll tell you that's part of progression, but not all of progression. So again, this is a fireside chat. If I had my way, this would be entirely conversational, but we're being videoed, and so I will try to be a little more discursive. So the science. When I talk to medical students, I run the clinic at Banner University Medical Center, the MS clinic, and I have almost always a third-year medical student or a neurology resident sitting in with me, and I say to them, question, is MS inflammatory or progressive? I said, by the way, you're not going to be able to get this one right. And mostly they will say one or the other, and I say no. They say the other, I say no. And the answer is because it's both. So MS is progressive. It is always a progressive disorder from before you were ever diagnosed to the last day on earth. But that degree of progression may increase over time. Progression is pretty invisible early on and becomes more visible too often late. Inflammation, mostly thought about relapses, is at its greatest early on and becomes less and less inflamed over time with some change in the way the inflammation occurs, and that change in the inflammation is more toward acute inflammation attacks, toward an inflammatory response that may be smoldering and hard to reach with our current medications, and I'll talk about hope there too. And so, Stuart, one of the things you kind of talked about is too few medications and where is the hope? Where is the hope for progression? So you asked the question, and so it is, to everybody's acknowledgement, frightening. Frightening before it's ever occurred, frightening when it does occur, and not at all hopeless. And that's what I want to convey. So maybe it's a time to talk about the phases of MS just so you hear it. And so that you hear kind of not just MS is relapsing remitting, and then it is secondary progression, and there's also primary progression. I want to broaden that lens, broaden that aperture, so that you think about MS in a broader way. We begin to think about MS currently before MS is ever diagnosed. You all know, all of you with MS, all of you who are so knowledgeable about MS, know that people will come in saying, yeah, I got diagnosed a week ago Wednesday, but number one, I might have had an attack 4 years ago. Number two, even if I've never had an attack before, I've been not myself for the past few months, more fatigued, ended up in the hospital for something else, etc. So there is a renewed interest, not just in the first event of MS, but in the prodrome. And we have epidemiologic information saying that in the year before diagnosis, the rate of hospitalization and medical utilization is much higher, meaning that something's going on before something's going on. And that's the first thing I wanted you to know. So MS was always there, or not always, was there for long before it was ever diagnosed. The usual is for us to talk about another sequence, not just the prodrome, but the radiologically isolated syndrome. I don't know if you all know that term, but people show up in my office all the time who are in a motor vehicle accident and got a headache or a head injury. They get an MRI. The MRI says, looks like MS. But the person says, I've never had I've never had optic neuritis or partial transverse myelitis or any neurological event that would be like MS. And the answer, it's a radiologically isolated syndrome. If the history is normal and the exam is normal and the MRI looks like MS, but no one's had an attack, it's not MS. It's a radiologically isolated syndrome, about a third of which goes on to have MS, particularly if there are certain prognostic indicators. So that's a next step. The next step is CIS, that's a radiologically isolated syndrome. Radiologically isolated, not clinical. The next one is a clinically isolated syndrome, where you have one event, optic neuritis. If that were true 30 years ago, 40 years ago, the clinician would say, this can't be MS, because MS must be multiple. It can't be one event, it is multiple sclerosis. We now know that if we treat that first event, we can reduce the likelihood of that second event. And so we now have connected the term clinically isolated syndrome. And if you've got that optic neuritis or partial transverse myelitis, optic nerve, spinal cord, or brainstem cerebellar event, and you've got a couple of lesions, we know your prognosis is highly geared toward having MS at an 80 or 90% level over the next 15 years. And so we will treat that in most situations as if it is early MS. The next one is relapsing MS, and that's the most common form of MS, the term you're most familiar with. You know the term relapsing remitting MS. There is some discomfort in the most thoughtful areas of MS to say we don't like the term relapsing remitting because it implies that it goes away. You have a relapse and then you remit, it goes away. We think it is relapsing MS, but that MS, even when it's quiet, hasn't gone silent. And so you'll hear relapsing remitting, but keep in mind there's another group that just likes relapsing. And then there's progression. Now, we only talked about progression a while ago, and now we talk about two forms of progression. And one is active progression, and the other is progression in the absence of relapses. Active progression means that so in relapsing MS, an attack, partial recovery or full recovery, stable, next attack. In progression, there is change or decline between attacks. And the FDA has now added, for all the medications we use, the treatment for active secondary progression. Progression with something else going on. More new MRI events, another relapse even with progression. Just keep these terms in mind. And then the last would be progression in the absence of relapses or late secondary progression. I would contend that if we talk about the biology we can think of as a big or a little, macroscopic, microscopic. Macroscopic, the way we tend to think about it, is atrophy. Now, I hate to tell you all this, but our brains are all atrophying. After age 30, we lose a little bit of brain every year. It's about 0.1 to 0.4% per year. So an 80-year-old brain is different from a 30-year-old brain. How old are you? 33? It's different. Atrophy begins probably somewhere in the early 30s, and we lose a little bit of brain every year, all of us. In MS, that 0.1 to 0.4 is greater. It's greater than 0.4. That atrophy is the macroscopic sign of progression. But on a cellular level, something must be going on little that's doing that big thing. And the little thing is loss of neurons. So why do you lose neurons? We know that if you injure a neuron during an acute attack, it won't live as long. We know that if you kill a neuron during that acute attack, it's gone. And somewhere at least between those two events, much of the engine that drives progression occurs. So for me, the major engine that drives progression is inflammatory loss of neurons. Either the inflammation that kills that cell, creates more loss of tissue, atrophy, or that injury that doesn't kill that cell, but doesn't allow it to continue on for as many years, and ultimately you lose it too fast. So that's the second bit. And my belief most strongly is that the way we have made a major change in the treatment of progression is by coming out with therapies for MS, disease-modifying therapies, and then coming out with more and more effective therapies for MS. So I became a neurologist in 1972, which means I've been a neurologist for more than 50 years. A couple years in the Air Force, arrived in Arizona in 1974. There were no disease-modifying therapies, nothing that could change the needle. 1993, beta seron. one disease-modifying therapy. It was 30% better than its placebo comparator, which may not sound like a lot, but 30% compared to nothing was hugely hopeful. We could do something for the first time. I will tell you, and I'll get to this later, we're better and better at using more and more effective therapies, and I would contend more effective therapies, including lesser risks and lesser inconvenience as we go along. That's also been associated with a reduction in the number of people who go on to progression or how early they go on to progression. Those are the things I wanted you to know. Now, going back to what you said. So I in my office, the conversation often is that I say, by the way, your MRI scan is stable. The patient says, so if my MRI scan is so stable, why am I getting worse? And I bet you that's a conversation that goes on in neurological and MS specialty offices all the time. The answer is when we're talking about being stable, we mean I don't see any new enhancing lesions, I don't see any new non-enhancing lesions, but what we're not talking about is progression. Why have we avoided talking about progression? We tend not to talk about what we're not good at. And once upon a time, we were pretty nihilistic about MS in general. So there's a story, and I'm about to tell a story. Forgive me. So Stuart, especially forgive me. This story I want to attribute to Joe Berger, University of Pennsylvania, professor. Joe Berger tells a story. 1965, San Francisco. Do you know the story, Chris? No. 1965, San Francisco. An industrialist who had made a great deal of money, was in his 50s and having a life crisis and didn't want to do that anymore. He wanted to do what he really wanted to do, which was balloon flight. So he cashed in, sold his business, got the best balloon money would buy, all the technology, at least as of the 60s, bought the best balloon, best technology, took off from San Francisco to New York, solo flight. Winds were great, life was great, but Kansas, the winds died down, and he was lost. In this instance, there was a piece of good fortune. He saw a man below him on the ground. He brought the balloon down, and he said to the man, "Sir, I'm lost. Do you know where I am?" And the man on the ground said, "Yes. You're in a balloon." The man in the balloon said, "Are you by any chance a neurologist?" He said, "How did you know?" He said, "Because what you told me was absolutely accurate and absolutely useless." And that was MS before 1993. It was nihilistic. We could educate, we could talk, but we weren't any good at making a difference. Once we got disease-modifying therapies that reduced relapses, reduced inflammation, we were better and better, and so we talked about what we were good at. And we talked about, here's our newest disease-modifying therapy that treats relapses, that reduces inflammation. We've now got 25 and counting, and we recognize the unmet need. So both of you talked about unmet need in a way. You all talked about unmet need. We don't think we talked about it enough. We don't think we looked at it enough. We don't think our threshold for acknowledging it was enough. And yet it's the existential fear of everybody who's diagnosed with MS. So when anyone's diagnosed with MS, if they're not really good at denial, it is, what's going to become of me? What's going to become of me in 10 years? Will I marry? Will I keep my job? Will I still be acceptable in social settings? Will I walk okay? Will I have difficulties with this, that, or the other? Progression is the existential fear. But because we weren't very good at it, we didn't talk that much about it. We now recognize that we need to be looking at progression much more intently. And that means we need to say, it's not just progression because last time I saw you 6 months ago, you weren't using a cane and today you are. So that's progression. Sure, but that's way too gross. It is, what's your cognition doing? Are you having more trouble with memory and multitasking and processing? What's your bladder doing? Are you racing there faster than you had to? Did you not get there on time? How's your walking? It doesn't mean that you're falling, but are you now having more imbalance on steadiness? Et cetera, et cetera, et cetera. We are now asking those questions and often testing those questions. It means we can be using things like the symbol digit modality to test the processing speed of an individual over time. We can use a 25-foot time walk to see how people are walking and whether they're slowing down. But we can also ask questions. How are you doing? And how are you doing becomes an important part of knowing whether a person is having progression or not. Now, I would say, what do we do about progression? Kind of at least part of the question. There are a lot of things we can do about progression. Number one, there's a difference between progression and worsening, and that's what I wanted to say. Because you're worse this year than you were last year, may indicate that there is a biological loss of neurons and progression, but it may be worsening for other reasons. And so the first task of the neurologist is it something treatable? Have you quit exercising? Have you been able to stop smoking? Are you eating healthy? And again, emphasis on are you eating healthy, not are you losing weight, but are you eating healthy? Are you maintaining your socializations? Are you maintaining your intellectual activities? These are lifestyle and wellness interventions. Next, are we treating comorbidities? If you're depressed, you're worse. If your diabetes is out of control, you're worse. If your cardiovascular status is worse, you're worse. So are we paying attention to the rest of your biology? Are we making sure your diabetes is under control, that your depression is being acknowledged and treated? Are we watching your cardiovascular status? A neurologist used to have to do this much in the world. I would contend, microphone off. The role of an MS doctor is much greater. I used to say you shouldn't expect much from us. We're not that good, 1960. Now you should be expecting much more from us, including progression. What else about progression? One particular thing I wanted to mention. We think that a lot of progression we're now looking at it biologically differently than we used to. We used to think that all we had to do was use the right medicine at the right time with the right power early. Now we recognize that a lot of our medicines work on MS in the bloodstream, but don't get into the brain. So if you all are aware, great. If you all aren't aware, I'm the first person to say it. Hear the term BTKI, Bruton's tyrosine kinase inhibitors. It's a new enzyme molecule, small molecule in MS. Virtually every company has one in phase 2 or phase 3 trials. And their unique advantage is, number one, they're small, they actually get into the brain. If a lot of late progression is smoldering progression, smoldering lesions that you can't get to with our outside-in meds, maybe you need an inside-in med that gets into the brain itself and gets to the site of the smoldering, and in that way can reduce progression. That's what we're hoping. We'll probably see the first agents. We've been involved in that research, not surprisingly. We'll be seeing the first of those agents, I believe, about a year and a half from now. So summer of 2024. But that's a hope. So keep your eye on that one. What's the problem? The problem is the one you all acknowledge. What's the hope? The hope is agent that we've noticed, that we're paying attention, that we're picking it up earlier, that we've got better agents to use in active progression, but also better agents to use that get into the brain and deal with the adaptive and innate immune system, not just everything right now is adaptive immune system. This is adaptive and innate immune system. It's going to be we hope it's going to make a lot of difference. The other side of it is we care, we're watching new agents, but we're also watching worsening. So don't always believe progression is the biologic. Think about progression sometimes being the worsening of everything else, and we should be paying attention to lifestyle, comorbidities, symptomatic management, and our disease-modifying therapies. Good. That was my first topic. So if you've got questions, I'd love to have you ask them now, but I think our format is hold on to them. Think about them, remember them, write them down, do what you got to do. Second, a discussion of our therapies. I'll be a little briefer, I think. I know the last one I'll be very brief. So Stuart, otherwise I'll run over time. So I'll be a little brief. I can keep going? All right. So therapies. My story about the balloon was a story about everything other before 1993. No disease-modifying therapies. It meant someone would come into my office. Remember, I'm now practicing for 21 years before I have the first available disease-modifying therapy. It meant someone would come in and I'd say, here's what MS is, we'll be with you during this time. And if they said, how am I going to do? The answer was, I hope for the best, but I can't change it. I can't do anything about it. If I had known a little better, I would have said, you can. Stop smoking, start exercising, eat healthy, et cetera, wellness. But in those days, it was such a different conversation. A conversation really based on impotence. Now, it's very different. People have various numbers for how many agents we have. I've tended to light on the number 25. So I say we've got 25 agents and counting. How do you classify? How do you make sense of it? I will say the National MS Society has wonderful data and wonderful accounting on the medications we use. MSAA, the MS Association of America, has put out a tool called the Ultimate Guide to MS Therapies. Do you know about that? Ultimate Guide to MS Therapies. It lists all the medications and someone talking about each one of them. So people you know, if it's Heidi in Washington, D.C., or Barry in St. Louis, or Annette Okai in Texas, there are people talking about each of these agents to try to translate it to you. So there is an Ultimate Guide to MS Therapies that talks about each one. How could you divide them? You could divide them by vehicle. Some are injections, some are pills, some are infusions, IV. All right, that's one way. You could talk about them in terms of some of them are immunomodulators, changing the immune system, but most of them now are immunosuppressant. They also damp down immunity and autoimmunity. A second way to deal with it. You could talk about a concept that you all don't think about much, and that is maintenance therapies versus induction therapies. Almost all the medications we use are maintenance. You're 23 years old, and I start you on the medication. Your neurologist starts you on the medication, and you say, how long will I be on it? And the answer is probably another 40 years. You will maintain this agent or its cousin, or the one you switch to, over the next 40 plus years. There are 3 agents that are called, those are maintenance meds. There are 3 that are called induction meds. One of them is stem cell, a short-term therapy with a hope that you go into remission. One that you may know of was called alemtuzumab, a short-term therapy with a hope you go into long-term remission. The third, which is one in more current usage, is Mavenclad. 10 days in June, and so 5 days in June, 5 days in July, nothing the rest of the year. Next year, 5 days in June, 5 days in July, and then you're done. Each of these therapies has about a 60% chance that it will change the way the immune system remembers MS, so that you will have the option of going into long-term remission without long-term immunosuppression. Those are induction therapies. I'm very keen on that, but that's a third way of looking at it. The last way of looking at it, and the way that I often find myself looking at it, is power. MS is at its most inflammatory early, when you're youngest, and it's least inflammatory when you're oldest. So I said it's always inflamed, but the inflammation goes down. Just as before I said it's always progressive, but the progressive or degenerative aspect always goes up. There are, I think, orbits of power. So the orbits of power for me are the earlier orbit, which was the injectables, the interferons that many of you know, and the copolymer that you know, Copaxone, Rebif, Avonex, et cetera. Those are legacy meds. Anteriflunomide, all basically about 30% more effective than placebo. For some people, that's just right, depending upon their attributes. Middle range. Those are two groups. One called the fumarates, and that'd be the Tecfidera, Vumerity, and Bifurtam. So one more, fumarates. There are some that we call the S1Ps. The S1Ps have 4 different ones: Gilenya, Zeposia, Mayzent, and Ponvory. All of them have work on a different mechanism, and they're pills in the middle level, 50% or more better than placebo. At the highest tier of efficacy is a 70% group, a group that has reduced the likelihood of attacks down to 1 every 10, 11, 12, down to 1 relapse every 10, 11, 12 years. So we're getting better and better at power. I am someone who philosophically, I was once at a round table with primarily academic neurologists out of the University of Colorado, and the then chair, John Corboy, asked the group, "What's your philosophy of treatment?" And it was clear to him that after each of us spoke, that we were all treating ad hoc, that we didn't have a philosophy. He thundered, "None of you have a philosophy. I have a philosophy. The philosophy is the early use of high efficacy therapies." I actually have a strong belief in that philosophy, and that is we should be using our best agents early and not our best agents late. So I think we use our best agents at the onset, not too late. I later said to John Corboy at a meeting, "John, I've adopted your philosophy, but it's not universally accepted. There are a lot of people who start with the lowest agent and escalate." He said, "There is a consensus between the people who are right, like me, and the people who are wrong." And with a little acknowledgement, actually on the Ultimate Guide to MS Therapy, there is a debate between a father and daughter. You may imagine who that father and daughter are, about whether or not you start early with high efficacy therapy. The father took that role. The daughter said, "Yes, but you need to take the individual into account too." She's right. It's my daughter. So with that having been said, I would say the other question is really how do you use them? For me, it's when you start them. When you start your therapy, now, as early as possible, except if they're extenuating circumstances, as early as possible. You don't wait. When do you change them? You change them when there is a breakthrough clinically, relapse, a breakthrough radiographically, and that means a new MRI event, generally, not always, or when the person you're treating is intolerant to the medication you gave them, or it's causing side effects that aren't okay, or adverse events. If their liver enzymes go crazy, if something happens to the other systems, you need to think about changing. So do we change? Yes, but not for no reason. Change for breakthrough clinically or radiographically, breakthrough for intolerance, can't stand that medicine you gave me, breakthrough for hazard. And then when do you stop? When do you stop is actually our part of our greatest puzzle right now. We know that as you get older, your inflammation diminishes, just as we said. If your inflammation diminishes, your need for power diminishes, and at some point in time, the benefit-risk ratio of these agents we just gave you may disappear. And it may be that the benefit went down because the inflammation's gone down and the risk has gone up because you're older. And at that point, we ought to reassess. When does it occur in populations? Probably somewhere in the 50s and 60s and 70s, 50s and 60s. When does it occur in the individual? We never know. We'll get better at understanding when the inflammation is still ongoing and when we shouldn't stop, using a lot of blood markers. We'll get better at understanding when we still need to keep it going. We're not there yet. So for the N of 1, we really don't know. That's my comments on, only one more comment on disease-modifying therapies, and that means it isn't enough. It isn't enough when we get the right disease-modifying therapy. My constant message is that's part of the equation. We need to also think about comorbidities. Are we watching over your diabetes or somebody? Are we watching over your hypertension or somebody? Are we watching over your lifestyle? The tobacco, the exercise, the diet, and then the wellness aspects, mood, social integration, et cetera, et cetera. It's MS, as you know, isn't about some tiny aspect. It's about keeping an eye on all of you. That's my comments on treatments. Last and briefest. All right. Now, I'm looking over at Stuart because I always think that I'll overrun my time. but
You have plenty of time.
all right then. Symptomatic therapy. What are the symptoms of MS? I'm going to have a shout. Now, what's the most common symptom of people with MS? Thank you. That was my form of interaction. Yes, fatigue is the most common symptom in MS. Thank you for being willing to be participatory without a microphone coming around. But it ain't the only one. So fatigue, cognitive symptoms, including multitasking and memory. Multitasking and processing speed. Bladder function, pain, mood, anxiety and depression. Everybody talks about depression. People don't talk enough about anxiety. I am the father of a psychologist, I'm the father of a neurologist, I'm the father of a psychiatrist, and so I think in those terms all the time. But mood, walking, gait, all these things are MS symptoms and more. I don't want to talk about each one of them except to say treating these aspects of MS is crucial to quality of life. I start you on a disease-modifying therapy, and I say, you'll thank me in 10 years if the medicine works and it doesn't cause side effects. With my symptomatic medications, you should be saying to me, will it make a difference today? Will I feel better now? That's the virtue of the symptomatic medications, is to try to improve quality of life now. And so how do we do it? For bladder function, there are bladder medications. For gait, there are medications for gait, including physical therapies. For cognition, there's speech and occupational therapies. I want to use maybe one symptomatic just to think about it. So if you said correctly, thank you, that fatigue is the most common, those of you who are willing to raise your voice a little, then the question is, if fatigue is due to, is the most common symptom of MS, if I have fatigue, is it just a done deal and I don't need to think about it anymore, and my neurologist, MS specialist, also doesn't need to think about it? I would contend that that's not the right answer. I sometimes play a game again. Forgive me for audience interaction. How many of you in the room do not have MS? Of you who do not have MS, of those of you who have MS, how many experience fatigue? Almost every. Of those of you who don't have MS, how many of you experience fatigue? So, I'm only saying, by the way, you may not be able to see, the camera may not be able to see audience. Almost everybody raised their hand for number one. Almost everybody raised their hand for number two. Is that correct? I'm not overcalling it. Not everybody has fatigue, but it's very common. But MS fatigue's different. But I point out that if everybody's experiencing fatigue, then we can think of fatigue as being only untreatably due to MS. So I say, if someone comes into my practice with fatigue, I have an obligation. How are you sleeping? If you're getting up every 3 hours to pee, or getting up every 2 hours anyway, that can interrupt sleep and can create fatigue. Number two, if you're depressed or anxious, that's associated with fatigue. Number three, if you're in constant pain, it creates fatigue. Number four, if you're on medications that create fatigue, the medications that create fatigue create fatigue. And so what I'm trying to convey is, if we take it superficially, for any of these symptoms, We may get it right by the odds, but we get it wrong. And we ought to be diving deep and saying, not just, is this MS, do we need to treat you with a stimulant, but rather, do we need to think about origins that occur to human beings, including human beings with MS, so that we really think about this. If you have 15 minutes to see a patient, and a lot of neurologists do, it's hard to ask those in-depth questions. If you give yourself more time for each patient, and I would contend that for MS it is essential, then those questions can and need to be asked. Now, what else would I say about symptom management? I said it's the way to improve quality of life now. I've said you've got to go down deeper, and I would contend it also is a time when you think about the fact that treating MS requires a village. I'm not a great pain management doc, but there are some terrific pain management doctors. I can refer to those people who really do a good job. I may know a little bit about the mechanism of the bladder in MS, but a neurourologist knows more. I can refer to that neurourologist and do. If it's depression, sometimes I can talk about it, anxiety, sometimes I can talk about it. Sometimes I even will prescribe something. But I'm the father of a psychiatrist, and she knows much more than I do, and I can refer to her or to others to choose the right medicine for the right person to make life better now. And so what I'm saying is a bunch of things. One is, symptomatic meds help now. Don't underutilize them. There's more than just symptomatic meds. There's also physical therapy, occupational therapy, speech therapy. There's also that whole array, psychiatrists, urologists, et cetera, bringing us to the idea of who should be taking care of MS. When I arrived in Arizona, 1974, there was one MS neurologist in the state, Dr. Bill Sibley in Tucson. We now have a number of people who are interested in MS. MS was previously taken care of by good general neurologists, but not MS specialists. The first advance is how many more of our patients are seeing people who actually focus on MS, and I would contend that the people who focus on MS are especially up to date, especially helpful, especially knowledgeable about what can be done broadly, and often take more time. And then I would contend that in addition to the advantage of a good MS specialist, there's an advantage to centers, either centers with or without walls, so that other people get involved. It ain't just us. I think that's what I wanted to say, Stuart. Those were three topics. Topic number one, progression. Topic number two, disease-modifying therapies, including those which weren't medication. And number four, the need for symptomatic meds for quality of life, but not using them superficially, and the need for a village. So with that, I will turn this back over to you, Stuart.
Thank you very much, Dr. Hendin. We want to give him a round of applause. I do know that you definitely made a difference, because we've got over 60 people online, and we've got a lot of questions already online. So I'm hoping that I'll be running around the room here too, because I gained too many calories this week running around your beautiful state. And so I'm hoping that you all have questions for me as well. Anybody have a question out there? Please raise your hand.
Okay, let's cycle back to progression. What is your opinion about whether or not progression is relating to the reduction of the residual reserves in the brain?
So great. So you've done your reading. So there's a fellow in New York who you know, Stuart, named Steve Krieger. But there's also a fellow who you may or may not know, those of you who've been around for a while, Tim Vollmer. Tim Vollmer was the head of the program at the Barrow Neurologic Institute, went off to the University of Colorado, where he co-chaired the department with Dr. Corby, about whom I spoke, and now has retired to Prescott. Both of them and a fellow in London named Gavin Giovannoni have really furthered this idea of brain health and brain reserve. I'll add one more name, Augusto Miravalli in Colorado. All of them have talked about brain health and brain reserve. What is brain reserve? We're all built with, You may know, some of you who are old enough may know an old Timex watch commercial in which they said, takes a licking and keeps on ticking. That's brain reserve. Brain reserve means how well you can take a hit in terms of your brain function. Can you get a lesion and still function okay? We didn't invent that, by the way. I don't know if you know that the MS people took over, but we didn't invent it. It was the Alzheimer's people who said, isn't it odd? There are people who have lots of neurofibrillary tangles and plaques, look like a bad Alzheimer's brain, and they're doing okay. There are other people who don't have as much disease, and they're not doing okay, implying that there is a difference in our ability to take a hit. Sometimes it's odd stuff. The bigger your brain when you're 10 years old, just the bigger your brain, the bigger your reserve. The more neuronal complexity, fine. But it's also how you live. Do you smoke? No. Do you exercise? Yes. Do you maintain intellectual activity? Yes. So what do you do to maintain it? Do you take a disease-modifying therapy that reduces injury? Yes. So it's a bunch of things. I'm a great believer. Steve Krieger, as you know, did a beautiful sort of a diagram or cartoon of a swimming pool. And when the swimming pool water goes down, like the brain reserve goes down, the symptoms are more apparent. So our job in many ways, if you ask Tim Vollmer or Gavin Giovannoni or Augusto Miravalli, who is about to become chairman at Rush of the MS department, leaving Colorado, or Steve Krieger, you will hear that our job is to protect the brain reserve. Some of it is a done deal. It's our size, our complexity, but so much of it we can do something about. Thanks.
Thank you. We're in the back of the room. And when you said Rush, you're talking about he's going to Chicago?
He's going to take over the program for Dr. Dusan Stefosky. So he's taking over from Dr. Stefosky. Yes. He's wonderful. He'll be a wonderful addition.
He started in Florida.
He did. He was in Florida.
That's right. That's right.
He started in South America, thought he would become a classical pianist, decided he was going to be a neurologist, has been very active in wellness, was Colorado for training, Florida for a while, back to Colorado, now to Chicago.
Cool. All right, question here.
Can I expect my MS hug to get worse or even better? And what is a treatment available for MS hug?
For those of you who don't know what an MS hug is, we always think that the term is kind of a misnomer because a hug is kind of nice. Someone just gives you a hug because they love you. That's not an MS hug. MS hug is an unpleasant feeling, often chest or thorax or even abdomen, sometimes limb, that occurs unpredictably, often briefly, sometimes more prolonged. We don't have a great bead on the origins of the MS hug. It's neuropathic, but its tissue of origin isn't always entirely clear. Is it muscular, in which case you'd think that the baclofens and tizanidines would help? Is it neuronal, in which case the gabapentins and pregabulins should help? Is it nonspecific, in which case the tricyclics and other agents may help? Because we don't have a real clear pathophysiologic origin, you'll see all of these agents used. The good news is it tends to flare and then die away, sometimes only to flare again. But I do not predict for anyone that this is going to be a lifelong plague.
Great, thank you. Anybody else here have a question? All right, how about neurofilament light?
Neurofilament light. How many of you, again, just so I know, how many of you know neurofilament light? How many of you don't know neurofilament light? How many of you hate to raise your hand for these kinds of questions? Thank you. Stuart's brought up an idea. The question is, how do we understand neuronal injury and progression, for example, in MS? Neurons have in their skeleton a chemical called, or a protein called neurofilament light. The neurofilament light's part of the axonal structure, and if the axon is broken down, it's released into the spinal fluid, and then released in tiny, tiny amounts into the blood. We now have such good technology that we can measure the amount of neurofilament light in the blood and say, here is normal. Here is normal when you're older. But there's X amount being released into the blood, indicating ongoing neuronal injury. We think that it may be relevant, particularly for the future, in telling us something about progression, telling us something about the effectiveness of our therapies. After all, if I start you on a therapy and the neurofilament light goes down, it means neural breakdown has been going down and things are good. But if it didn't go down, it may mean that we didn't have such a good agent. I would contend that that is one marker, and that my current discussion is neurofilament light is the marker of the day. It's the one that everybody focuses on. Don't get too obsessed with neurofilament light. There are other markers. In the past, the marker was always MRI. But there are other markers above and beyond neurofilament light. There's one called GFAP, for example, that looks at the glia and astrocytes. There's a whole other array. There is a group out of San Francisco coming up twice now, called Octave, that has a biochemical array that looks at not just one tissue, but multiple tissues, with the hope that we can use this kind of array to predict outcome. If it proves as successful as hoped, we won't have just one element of neuronal breakdown, but multiple evidence about microglia, astrocytes, neurons that tells us something about the patient's course, prognosis, response to therapy.
Okay, I'm going to start with some questions that are online because they're just building, okay? First one, question, my neurologist feels that once you reach 60s, MS-DMTs are not as effective and stopping doesn't increase progression.
Repeat that. I know what the gist of the question is, but
the gist of the question, obviously, is that this person is being told by his or her neurologist that it's probably a good idea to stop taking your medicine in your 60s because it's not going to stop or increase your disease progression.
Stuart, how old are you?
64.
Oh.
Will I stop? Will I stop? No.
So here's the answer. I'm gonna again put the microphone down just to do a hand show. MS starts out with this much inflammation, and that inflammation diminishes over time. MS begins with this much inflammation, and the degree of inflammation goes down over time in populations. So if you get 100 people with MS and measure inflammation, that degree of inflammation goes down over time. Autoimmunity goes down over time in MS. The power of inflammation goes down over time. If this is the benefit of the ratio, when you're highly inflamed and you're not highly inflamed anymore, the degree of benefit will go down over time. When you're young, the risk of the medications in terms of immunosuppression may be this, but the immunosuppressive risk may go up over time. And at some point, we believe those lines cross. The decreasing inflammation and the increasing risk. In populations, we judge that that's happening in people's 50s and 60s. In the individuals, we don't know. And that's where we're hoping for these markers. So if you said to me, the markers I just talked about, the array of markers, it may be that I say, you are immature. You're 65 years old, but you're immature immunologically. You still need to be on it. You're 62 years old, but your last event was a while ago. Dr. Corboy, who's come up now twice, did a study in the University of Colorado asking that very same question. If we take people, 50s and 60s, who've been free of any events for the past 10 years, 10 years, and take them off their meds, or leave them on their meds, half them off, half them on, will some do fine in each group? Yes. Can you show in a group the inferiority of that decision or superiority of that decision? No. Is that a good enough answer for me today? No. I don't know for sure whether you're the immature one or you're the burned out one. And so I tend to say this is a patient dialogue. So in my view, I say, Chris, You don't have MS. But Chris, you're now 68 years old. I just made you 68. You're 68 years old. You're on Agent X. You haven't had an event for 4 years, 6 years. Your MRI has been quiet for 6 years. And I say to myself, is he on a high-risk medicine or low-risk medicine? Because we can adjust that. I say, Chris, do you want to stay on or not? He doesn't. So Chris doesn't want to stay on the medicine. So I say, all right, Chris, let's take you off. We'll watch you. You're a good candidate because you've been free of events for a long time. You look good. We can de-escalate or even stop. I'm going to make you different. You're now 62 years old. You're going to give me a different answer. Should I take you off the medicine? Give me a different answer. You don't want to go off medicine. You want to stay on medicine. Yes. And so is the medicine you're on right now one where the risk is acceptable to both of us? If it isn't, I can de-escalate. But I can also keep you on and watch you. We don't know enough yet from my perspective for me to make an absolute decision without this being collaborative. And that's all I mean to say.
So the other side of the coin that I'm going to now hit on is, how do you all know that I am not showing any disease progression and I'm not showing any worsening because I have been using my medication religiously for the last 13 plus years?
Exactly. So you're saying to me, isn't this still a bit of the unknown? And I'm saying back to you, Stuart, that's exactly what I meant to say. That when I know the answer, so I gave you an answer when to start. I said, when do you start? Now. When do you start your disease-modifying therapy? Now. When I came to when do you stop, my answer was, we're still working on that one. And I contend that we know about populations, we don't know about the N of 1. And that's what you're bringing back up. Do you understand the idea of an N of 1? I'll tell you about the idea of an N of 1. So imagine we're in Las Vegas. And and you're the dealer. Chris is on one side of me, you're on the other side of me. The dealer has a 9 showing, and I have two picture cards. I have a king and a queen, the deal comes around to me, and I say, I'll take a hit. Chris says, sir, I don't think do you know this game? I don't think you want to hit. The dealer says, actually, sir, do you really understand this game? Because I don't think you want to hit. You say to me, don't take that card, that's my card. I don't want you to take that card, don't take it. I say, no, I want that card. I get an ace. The odds only knew what would happen 100 times. The odds didn't know what would happen once. The N of 1 is once. So my contention is we know about populations better and better. We still don't know enough about the N of 1 to make that decision independently for that N of 1. I can say, let's de-escalate to maintain safety. I can say, let's stay there. I can even say, this might be a time to get off, but this for me is collaborative. This is not a decision that I make that I think I am smart enough to make in the absence of a discussion.
Okay, thank you.
And that's, by the way, Las Vegas, San Francisco, we're getting around. Good.
Thank you. Next question, similar to what we're speaking about. A person asks, can someone ever stop taking a disease-modifying therapy, such as Tysabri?
So there are a couple of medications that are different from the others. And I would contend the two that are the most obviously different are Tysabri and its cousins, Tysabri, and what we call the S1Ps. I named them. Those are Gilenya, Mayzent, Zeposia, Ponvory. Those medications don't lyse or destroy cells. They sequester cells. They sequester them in the bloodstream or in the lymph nodes, so that if you stop them, all of those cells that were sort of sleeping where they were now are awake and can go where they wanted to go, autoimmune. They can cause rebound. So I believe that if you need to stop any of those medications, you need to stop the interferons or the copolymers or Aubagio, teriflunomide, or the B-cell depleters, or the other agents, the fumarates. Those you can stop in the right situation. But Tysabri and the S1Ps, you need a plan B, because you can get a rebound when those angry cells are there.
Thank you for that. Next question, similar again. Person writes that he or she has been on bedaciran for over 19 years and is afraid to make any change to therapy. Dealing with some progression, but feel it's dealable. And what are your opinions on changing or not?
So you know in advance that I don't know enough to be able to answer this one. So let's take it as a general comment. As a general comment, stopping meds, there are times when I'm quite definitive. There's a 27-year-old who says to me, not I want to get pregnant, not other things, but I just want to stop my meds. I want to do it by diet alone, et cetera, et cetera. I say, no, please, in the end, your opinion is the one that goes because you're autonomous and you make the decision. But I will advise strongly that at this age group, let me try to persuade you to stay on. The older the patient, the calmer the situation. As we've talked about, the more that this is discussable. Tell me she's 80. I'm 80. Tell me she's 80. Sure. Tell me she's 30. Then if she doesn't like the bedaciran, we say, by the way, there are 24 other agents out there. And so we can talk about not stopping, but finding one that's the shoe that fits your foot better.
Okay, thank you for that. There's a question here which I'm going to reformulate so that way you're not answering for a person directly with MS, but what about those that say they were diagnosed in their mid-30s and they were on a disease-modifying therapy for a period of time and said, hey, there's nothing wrong with me, I'm going to stop. But now they're 20 years later and they feel like they've gotten a lot worse. Can they go back onto that therapy, or should they be thinking about newer therapies?
Yes.
Thank you.
By the way, you're used to long answers from me. Were you pretty impressed? Thank you.
All right, next person. Anybody out here yet? Oh, I got to take this one. Make me stand up.
You talked about different biomarkers. Is there any kind, or will there be a biomarker to tell you which medication is going to work best for which individual?
Ultimately, yes. I try to tell people how far the science has advanced since I came out. I scare people sometimes, but the day I left training, so I finished my residency in 1972, the summer of 72, in St. Louis, Missouri, Washington University. There wasn't a CT scanner in America yet. The answer to questions of hope is, oh yeah. The next question is, how soon? 3 CT scanners came to America, one to Washington University, one to Harvard, one to the Mayo Clinic. My great question, which Mike still there? No. I don't know that anybody knows the answer to this one. Shane, you could. Do you know who financed the first working model of those CT scanners that came to America? Who was that, Shane?
I have heard, but I cannot think of it right now.
The Beatles. It was the Beatles. It was a singing group, the Beatles, who financed the first working models of CT scanners that came to America. All I mean to say, kind of circumstantially before I answer your question, I think the biomarkers will, at some point, be able to say, if not, this is the right medicine for you, but they may, then this was the wrong medicine for you. You started X and it was wrong. It was suboptimal. But from that, I think we'll have yes. My hopefulness always comes from where I've come from. If I began in neurology before there was a CT scanner in America, imagine the hopefulness that I feel, that 0 disease-modifying therapies, no CT scanner. Imagine how hopeful I am about the science moving forward. I have a daughter who's a neurologist, MS neurologist, Dr. Travis. What will she be doing that I didn't? What will her children, she has 8 of them, what will her children be doing that I didn't, et cetera, et cetera. So I'm hugely hopeful. Stuart.
Thank you. Next, is there any way that a person with MS can donate blood?
Yes.
Yes, great. Next, I'll get there in a moment. Thank you, though, for raising your hand. It helps. All right, next, can we expect a drug to rebuild myelin?
I've been involved previously in research for myelin repair. The research trial that I did was an unsuccessful attempt to do a kind of a genetic change for those factors that prevent remyelination. We did, with Biogen IDEC, a research trial for an agent to see if we could increase remyelination or create remyelination. We didn't do so in a way that made a difference. I've wondered whether our approach was wrong. One of the ways the way we did it was to try to block a gene that blocks remyelination. If you block the gene that blocks remyelination to create myelination, I think it may be a different mechanism that gets us there. It may be something like looking at the cells that make myelin, the oligodendrocytes, and to try to grow the oligodendrocytes and then send them to where they need to be, and then to make them act where they are. So there's still trials in remyelination, but that we all 10 years ago I thought that was a hope for today. I think it is a hope, but not for today.
Thank you. By the way, I'm going to take this person's question here, and I see there's a hand up there and another one here. That's great, because not only will they learn from their own questions, but you all will too. So if you have any questions, please raise your hand.
And Stuart, at some point you're going to tell me that Chris needs his time,
Yes.
and that I need to vacate this place, and I will
Well, that's
say
only
yes.
if you need the bathroom that quickly.
My question is, I know there's specialists in neurology that specialize in MS. I've had, over the years, had trouble finding specialists for physical therapy or specialists, that know how to work your muscles appropriately for someone who has MS versus somebody who is being repaired because they have just a leg
Yes.
injury. So my doctor seem to have that. So is there now in Arizona more
Absolutely.
special?
Yeah, absolutely. I remind me later, I'll give you the name of the places where I think there are places that do good general rehab, probably places that do mediocre general rehab, but places that do good general rehab. There are places that really focus on neuro rehab, and there are specialists that I think, I'm going to name a name actually. There's a woman named Desmond Bernstein at St. Joe, as an example, who I think is so skilled and excellent that she makes a difference. Now you say, but everybody can't go see Desmond. But what I'm saying is, by example, there are people who are interested in MS, who know MS, who are really wonderful human beings and treat. And so the answer to the question is yes, that's a name. But think about Banner, think about St. Joe, think about Swan, think about individual places. But you want someone who is A, knows their stuff, B, cares about MS, and knows something about MS particularly, period. Not just a good general rehab.
Two-part question. If mom or dad have MS, statistically, what are the
Sure.
statistics that show that the kids might have it? Is
Sure.
it higher than the general public? And two, second part of the question, our adult children are early 30s and late 20s, and there's never a good time to get MS, but is it a good time to have MS?
That's interesting. I'll answer both. The first part is the statistics of family. So we know that if you're just an American running around, your chance of getting MS is about 1 in 1,000. If your mom or dad have MS, your chance is 2 in 100. Now you say, 1 second, that's great. That is really a lot better than I thought. It's just 2 in 100. But you say, 1 second, that's also 20 times more than if they didn't. Then if you said, the one that I think is more telling, if you said, I'm an identical twin. I'm an identical twin. I'll make myself a girl. My identical twin sister, what's her risk? I have MS. I'm a 23-year-old woman with MS. What's the chance of my identical twin with vaguely identical genes getting MS? If this was purely genetic, it'd be 100%. It's more like 20 to 30%. And so it means that the genetics create susceptibility, but they don't create outcome. So if you have the genetic predisposition, it means your susceptibility genes are more and your defensive genes are less. If you don't get it, then you have the different rate. It's not one gene that causes MS. It's multiple genes that create susceptibility. If you got more of the susceptibility genes, you're more vulnerable. Less of the susceptibility genes, you're less vulnerable. But then you can do things. You can not smoke. You can, at some point, hopefully we'll have EB virus vaccinations, not today, and we'll be able to do something. Take vitamin D, get out in the sunshine. There are things you can do, but it's not genetically predetermined, even with all the same genes. Is this a good time to have MS? I tell people, by the way, I at the risk of being facetious, getting MS is not like winning the lottery. No one says, gee, I won the lottery, I got MS. Having said that, yes, this is, if you're going to get MS, now is an extraordinary time. And I wind up saying to people, this isn't your mama's MS. MS, the day I came into practice, the day I left training, led to early disability in so many, too many. I have residents and interns and medical students with me in my practice, and I say, what I want you to see is people with MS in my practice, and how many do so very well. We didn't have interventions that made a difference early on. Then we had okay interventions. The power of our current interventions and the state of our knowledge are so much advanced that when I make a diagnosis today, I am within a range very reassuring. I never could have done that 30 years ago. Thank you.
Okay,
Stuart.
we're over here. I want to let you know that we have 1, 2, 3 more that I know about in the audience. I have 4 more online, so if we can try to keep
I'll be very brief.
snug.
I'll be
all right?
very brief.
And not only that, I need you to keep the microphone closer to your face
I'll do
because
that
people
too.
aren't hearing
I'll
you.
do
Okay?
that too.
Thank you.
Stuart, is your opinion that I give long answers to short questions?
Some.
I agree.
Is MS geographical? Certain parts of the country have more.
I'll give a fast answer rather than a slow one. It is more common the further you move north from the equator. We didn't used to know why. We now say it's more common because there's less sunlight. To the extent that sunlight and vitamin D are protective, then it should be more common in Minnesota, than it is in Costa Rica.
Just going back a little bit with the stem cell transplants.
Yep.
Are they repairing myelin?
I mean, myelin can repair itself to some degree, but they're not really there to repair myelin. They're really there to stop the disease, stop the relapses, stop the inflammation, to reboot the immune system so that the immune system is less unhappy with myelin. So all of my induction therapies, called stem cell, Lemtrada, or Mavenclad, are really there to reset the immune cells so when they come back, they are less myelin aggressive, less myelin remembering, less myelin aggressive.
Thank you. As I'm getting to the back of the room, I'll ask you a question that you can answer, and that is, what can you tell us about PML and how it's affected by any of the newer medications?
The medication that was the most causative for PML was Tysabri. I think we've had a very good understanding of risk. A woman from Arizona, Denise Campagnolo, gave us the guidelines for risk with PML with Tysabri, allowing it to be used more and more safely. And again, that's the work of an Arizonan, Denise Campagnolo. Anytime you cause immunosuppression, you create the risk of PML, but not equally with each of the agents. For example, the B-cell depleters can, but do so rarely. Other agents do so in varying numbers. I would say any agent that is immunosuppressive carries that risk, but not equally. And we generally know how to assess risk and avoid that risk so that it's less and less likely to occur because of our using our agents more knowledgeably. And that means the fumarates, and that means the S1Ps, and that means the natalizumabs, and that means the B-cell depleters, et cetera. What is PML? I tried to say PML is a virally. There's a virus called the JC virus, John Cunningham virus. That virus exists in 50% of us, but it's dormant. It just sits there and sleeps there. If you create an immunosuppressive state, you can wake up the virus, and it can now, having awakened and mutated, can think it likes brain. It's called neurotropic. It can go to brain and cause demyelination, and 20% mortality.
Thank you.
Somewhat related. What do you think about the correlation between mono and at least primary progressive? The only two people I know that have primary progressive, my brother and someone else we grew up with, both had severe cases of mono as children. The siblings did not have that. None of the siblings have primary progressive, but the two individuals I know were diagnosed at about 60 years old, so more than 40 years after they had mono.
I got it. By the way, in another setting, I would be talking about 10 minutes about this answer, but in this one I'm talking 30 seconds. So there is a great interest in the virus that causes mononucleosis, which is the Epstein-Barr virus. Not just in primary progressive, but in MS. There have been studies, including one in the armed forces, that have shown that even if even if EB virus isn't the cause of MS, it is a necessary trigger for most people with MS. It's common in the general population. It's almost universal in the MS population. One of the things that interests me in terms of can we ever prevent MS is can we, in early childhood, create a vaccination for EB virus which eliminates that particular risk factor. That's still a way off. But your question is yes. The answer to your question is it's relevant in MS period and increasingly important to us.
Okay, thank you. I'm going to ask just two more questions, one of which is combined right here. Concerning bladder issues, is it possible for the bladder to start working correctly and stop working correctly? And secondly, what can you tell us about the baclofen pump versus other ways to control bladder issues?
So I'm going to answer this one briefly again. Bladder function, bladder is an important part of MS symptomatology in many but not all individuals. And I think the more there are motor problems in the lower extremities, the more there is correlating bladder dysfunction. It can be of all sorts, and that's why a urologist is often necessary, because they can say, MS can have various manifestations. In you, it's this and requires this intervention. In you, it's that and requires that intervention. Sometimes it's a medication, sometimes it's self-catheterization, sometimes it's neither. But it's a urologist who will generally answer it. Baclofen pumps really can be used, though I don't use them often, when you can't reach a dosage of baclofen to reduce spasticity through an oral route, but still believe it works highly effectively. The pump can be an answer.
Great, thank you. I have one question for everybody. Did you enjoy today's program? Great. Let's thank Dr. Hendin again. We hope that you all stay with us and learn from what we're providing. Thank you very much.